the standard of care right now is to utilize post-transplant cyclophosphamide. The standard dose, again, is at a double dose, so at 50 mg per kg on days 3 and 4, alongside calcineurin inhibitor and MMF. Really, this is because it's been compared to CNI-based prophylaxis alone, and there were significant improvements in terms of significant or clinically significant graft-versus-host disease. In other words, much lower clinically significant acute graft-versus-host disease and chronic graft-versus-host disease with post-Cy use. As I mentioned, while that was an improvement, what has also been seen on studies is compared to our old standard of care, there hasn't been a demonstrated improvement in overall survival. And that could be for a number of reasons, one of which being, while there is improvement in graft versus host disease control, overall transplant remains, sort of a burdensome process. And so for that reason, there are sort of baked in morbidities that still exist, particularly with post-Cy as well. But despite that, with an equivalent survival, with better GvH control, at least what we're offering for patients with post-Cy is a better quality of life at 1 year if we're not seeing clinically significant GvH. And that's why I think that represents really the standard of care. Sort of, if you want to comment on sort of recent developments, I think what's in this space right now that's, being investigated further is, as I mentioned, the addition of a JAK inhibitor, Ruxolitinib, to CNI-based prophylaxis. So we know just giving TAC methotrexate is not a relatively toxic treatment regimen for GvH prophylaxis. It lacks efficacy, in terms of preventing clinically significant graft versus host disease. But there has been a phase 2 study, performed or led by MGH that demonstrated sort of the addition of Ruxolitinib really attenuates severe acute and chronic graft versus host disease. So that's something that's under investigation and being compared against post-transplant cyclophosphamide. There have been also sort of graft manipulation studies, primarily led by ORCA, that look at sort of separating out populations of T cells that may impact graft versus host disease. And these studies are demonstrating potentially an attenuation of toxicity with that approach, and potentially, compared, to post-Cy, attenuated toxicity as well, with comparable sort of GvH outcomes.